Namaskar, my dear students. Today in the quick review section, we will be discussing a very important topic, that is posterior palatal seal. It is one of the important questions which is asked as a short note in the theory exam. It is also one of the favorite question of the examiners, and many MCQs are picked from this topic. So let's begin. First of all, what is a peripheral seal? You know, the peripheral seal of the denture, it is the area of the contact between the mucosa and the peripheral polished surface of the denture base. This seal, it depends on the proper extension of the denture borders, both in the width and the height of the denture flanges that we have formed. You know, they should fill the mucobuccal space and they should contact the cheek tissues laterally. Why this seal is important? What are its functions? First, it aids or helps in the denture retention by providing an air seal. Second, it prevents the food and the liquid from slipping under the denture. There should be no space. A proper seal should be maintained. Now, what about the posterior aspect in the maxillary arch? You know, there are no cheek tissues to seal the denture borders. So here comes the role of posterior palatal seal. Let us discuss this in detail. Posterior palatal seal area. So if we talk about its definition, the posterior palatal seal area is the soft tissue area at or beyond the junction of the hard and the soft palates, on which pressure within the physiologic limits can be applied by a denture to aid in retention. So first part of the definition is its location, that is at or beyond the junction of hard and soft palate. Second is its function, on which the pressure can be applied, and third is its purpose, to aid in retention. So the denture border, it should rest on this area, on the soft and resilient tissue, because it can move along with the denture during function, and thus it prevents the loss of the peripheral seal. Now we come to the functions of the posterior palatal seal area. The first and the primary purpose of posterior palatal seal is giving retention to the maxillary denture. How it does? It helps to maintain the contact with the interior portion of the soft palate. You know, the tissues that undergo shallow displacement while the patient is speaking, swallowing during the functional movement, so it should maintain a constant contact. Okay. Second, it reduces the patient's awareness of this area, and thus it also reduces the gag reflex. Third, it reduces any food accumulation beneath the posterior aspect of the denture. You know, there will be no leakage of the food beneath that. Then it reduces any kind of patient's discomfort when the contact occurs between the dorsum of the tongue and the posterior end of the denture. It will be very smooth for the patient. Then, very important, it should compensate for the volumetric shrinkage that occurs during the polymerization of the methyl methacrylate, which is the most common material nowadays used for fabricating the complete denture. Based on the anatomical landmarks, the posterior palatal seal area can be divided into two parts or two regions. First is the pterygomaxillary seal and second is the posterior palatal seal. The pterygomaxillary seal is the part which extends through the entire width and length of the pterygomaxillary notch, that is the hamular notch, and it continues 3 to 4 mm interiolaterally, approximating the mucogingival junction. This hamular notch is the area between the maxillary tuberosity and the hamular process of sphenoid bone. We can see in the picture nicely. Now this part, it contains the loose connective tissue with a thin layer of mucous membrane. Okay. Now if we talk about the posterior extent of the denture, denture should end in the hamular notch and it should not extend over the hamular process. Otherwise, it will lead to severe pain during the denture wear. Now, this is one of the multiple choice question asked, and it is also one of the viva question which is asked. Second is the post-palatal seal. Now this is the part of the posterior palatal seal that extends medially between the two maxillary tuberosities. Now let us discuss a vibrating line. What is a vibrating line? It is an imaginary line which crosses the posterior part of the palate, marking the division between the movable and the immovable tissue of the soft palate. And it can be identified when the movable tissues are moving. So that means it marks the beginning of the motion in the soft palate. Now there are two vibrating lines, the interior vibrating line and the posterior vibrating line depending on the location. And the posterior palatal seal area is the area between the interior and the posterior vibrating line. So let us discuss them one by one. First is the interior vibrating line. Interior vibrating line is the imaginary line at the junction between the immovable tissues over the hard palate and slightly movable tissues of the soft palate. So that means where the motion of the soft palate has just begun. Okay, now if we talk about its shape is Cupid's bow. It is not a straight line because of the projection of the posterior nasal spine. Another multiple choice question and a viva question. It always lies on the soft palate. Now, how we record the interior vibrating line? It can be located when we ask the patient to perform Valsalva maneuver. What is that? The patient is asked to close his nostrils firmly and gently blows through the nose. Okay. Or we can ask the patient to say aha in short, vigorous burst. Second is the posterior vibrating line. The posterior vibrating line is the demarcation between that part of the soft palate that has limited or shallow movement during the function and the remainder of the soft palate that is markedly displaced or shows more movement during the functional movement. Okay, if we talk about the muscle attachment, it locates the junction of the aponeurosis of the tensor villi palatini muscle and the muscular portion of the soft palate. Now, if we talk about its shape, the line is usually straight. How it can be recorded? It can be located by asking the patient to say aha in short but normal non-vigorous fashion. Okay, in the interior vibrating line, it was in the vigorous fashion or Valsalva maneuver. Okay, now this also marks the most distal extension of the denture base. Now we come to the techniques to record the posterior palatal seal area. The methods used to record the post-dam are four methods. First is the conventional technique. Second is the fluid wax technique. Third is the arbitrary scraping of the mastercast. And fourth is the extended palatal technique. We can remember these four techniques by the mnemonic FACE, F-A-C-E, fluid wax technique, arbitrary scraping, conventional, and the extended palatal technique. First is the conventional approach or the conventional technique to mark the posterior palatal seal area. First is the stage of recording. When we will record the posterior palatal seal according to this approach, we will do it in the trial base stage before the jaw relations. Now step by step method. First we will ask the patient to sit in the upright position. We will ask him to rinse with the astringent mouthwash. Then we will mark the posterior vibrating line. The hamular process, they are palpated with a T burnisher and they are marked. Then this T burnisher, it is placed along the posterior angle of the tuberosity until it drops into the notch. Then a line is placed with a indelible pencil through the notch and it extends 3 to 4 millimeter anterior-laterally to the tuberosity, approximating with the mucogingival junction. As we just discussed the extension of the posterior vibrating line, this will complete the pterygomaxillary seal. Okay, now the patient is asked to say aha in short burst in normal unexaggerated fashion to mark the central portion, that is the posterior palatal seal part. The posterior vibrating line is now marked, and we'll connect this line with the line of the pterygomaxillary seal. This will mark the posterior denture extension. Okay, now the trial base is inserted and these marks are transferred to the trial base, and then these lines are redefined and returned to the cast or the model to complete the transfer. If the denture bases they are overextended, they are trimmed accordingly. Next, we will mark the interior vibrating line. For this, the palatal tissues, they are palpated to determine the compressibility in the width and the depth. You know, where the glandular tissue they terminate, it usually coincides with the interior vibrating line. Okay. We can also ask the patient to do Valsalva maneuver, or we can ask the patient to say aha with short vigorous burst. Okay, this will mark the interior vibrating line. Then this line is marked and it is transferred to the cast. It will be in the shape of Cupid's bow because of the projection of the posterior nasal spine. Now, in the region of the pterygomaxillary seal, the interior and the posterior vibrating line, they will meet. They are confluent. Okay, now after transferring to the cast, we will prepare the cast. That is our next step. We will use Kingsley scraper to score the cast. The deepest areas, they are marked on either side of the midline to a depth of approximately 1 to 1.5 millimeter, and the median palatal and raphe part. Okay, it is marked for around the depth of 0.5 to 1 millimeter. Okay, because this has little mucosa, so it cannot withstand much compressive forces. Now, if we talk about the outline form of this posterior palatal seal, it will be it will resemble a shape of a Cupid's bow. Okay, the posterior and the interior border, you know, they should be tapered and they should blend with the palatal tissues. Now, if we talk about the advantages and the disadvantages of the conventional technique, the advantages are, first, the trial base has increased retention because we have trimmed it accordingly. Second, the patient can experience the retentive qualities of the denture. Third, patient has an idea of the posterior extent of the denture base. That is very important, especially if the patient has high gag. Then final adjustment during the insertion, they can be minimized. Now coming to the disadvantages, yes, it is not a physiologic technique. Okay, and second, the scrapping is approximate. You know, the excessive scrapping, it can lead to tissue compression. The second is the fluid wax technique. In this, it is called as fluid wax because the mouth temperature waxes are used to record the PPS area. First, if we talk about the stage of recording, this is mainly done after making the wash impression and before pouring the master cast. Second, rigid impression materials are used. The zinc oxide eugenol and the impression plasters are preferred so that the fluid wax, it adheres well to them. Now we come to the waxes which are used. Iowa, corrector number 4, HL physiologic paste, Adaptol. They are the mouth temperature waxes which flow at mouth temperature. Now we come to the step by step how we will record. First, the interior and the posterior vibrating lines, they are marked in the patient's mouth as described in the conventional technique. Then these lines are transferred to the secondary or the wash impression. Now the wax is painted only in the margins of the posterior palatal seal that we have marked on the impression. The position of the head and the tongue during this technique is very important. The patient's head, it should be positioned such that the Frankfurt horizontal plane is 30 degrees below the horizontal plane. It is at this position that the soft palate is at maximal downward and forward functional position. The patient's tongue, it should be positioned such that it touches the mandibular anteriors. While maintaining the head and tongue position, the patient is asked to periodically rotate the head. This will record the functional movements of the palate. Now the impression is removed after 4 to 6 minutes and examined. Areas which are glossy, they show tissue contact. Areas which are dull, they show that they have not come in contact with the tissues. So the dull areas, the more wax is added to them and the procedure is repeated. The impression is refined again till the feather edge margins are produced in the interior and the posterior vibrating line areas. Now we come to the advantages and disadvantages of the fluid wax technique. The advantages are, first, it is a physiologic technique. We are recording by displacing the tissue within their physiological limits. Second, there is no over compression, so it is avoided. Third, the posterior palatal seal. It is incorporated in the trial denture, so patient can have that added retention during the trying stage. Last but very important, there is no mechanical scrapping of the cast in this method. Coming to the disadvantage, the first is that it is more time consuming while we are recording the posterior palatal seal area, and second, there is difficulty in handling the material, and the added care during the boxing procedure while we are pouring the impression. The next method is the arbitrary scraping of the master cast. In this, the interior and the posterior vibrating lines, they are visualized by examining the patient's mouth. Okay, then these lines are approximately marked on the master cast. Then the lab technician, it scraps the cast 0.5 to 1 millimeter of stone in the posterior palatal seal area of the master cast. Now this technique is not advised because it is inaccurate and it is not at all physiological. Next is the extended palatal technique. This technique was advised by Silverman. He proposed that the posterior border of the denture, it can be extended 8 millimeter for the patients with class 1 soft palate. But this was not accepted afterwards, so it is not advised. Now there are certain troubleshootings which are associated with the posterior palatal seal area. And the distal border of the denture, it depends on this posterior palatal seal. Okay, so because of this, the distal border, it can be underextended, it can be overextended, it can be under post damped, or it can be over post damped. So let us discuss them one by one. The first problem is the underextension. It is the most common cause for the failure of the seal in the posterior palatal seal area. The main causes of this underextension is that, first of all, if we use fovea palatine as the landmark for recording the posterior denture border. Second, in high gag reflex patient, when we are unable to record a proper extension in these cases. Then failure to note the palatal configuration, whether it is a class 1, class 2, class 3 palate. Then if we miss recording the posterior palatal seal and we ask the laboratory technician to do the job. Now if it is underextended, then what we can do, we will have to reline the denture. The next troubleshoot is overextension. What is overextension? When the distal border of the denture, it extends onto the active portion of the soft palate. Okay, usually what happens, that patient always complains that the denture is coming out. So why this is happening? Because the active portion of the palate, it drapes against the hard unyielding denture base and it is dislodged. What are the symptoms of overextension? Patient will mainly complain of difficult or painful swallowing. Second, there may be areas of redness or ulceration in the posterior palatal area. Okay, or patient may also feel sharp pain, especially during function. So that may also be the overextension in the pterygoid hamulus region. Okay, now how to correct it? The exact areas of redness should be marked and it should be transferred to the denture using the indelible pencil, and the denture is shortened with a burr and it is again repolished and inserted into the patient's mouth. The next troubleshoot is under post damming. When the denture is not completely adapted in the posterior palatal seal area, the main cause is improper head position and the mouth positioning. Okay, during the recording of the PPS area. Second, how we can make the diagnosis. First, the trial denture is wet. It is placed in the mouth. Slowly, it is pressed into the position. Then with a mirror, the distal border is examined for the escaping air bubbles. If the air bubbles are present, it indicates an under post dammed area. Now, how we can correct it? First, during the registration, if we are doing the trial stage, what we can do, we can scrap the cast and we can add more wax during the wax up stage. And if the denture is complete, then we will have to reline the denture. The last is the over post damming. This is mainly caused because of the over scrapping of the cast. Okay, the symptoms of over post damming are during the moderate over post damming, there are signs of tissue irritation, inflammation in the posterior palatal seal area. And if there is severe over post damming, then the posterior border, it gets displaced inferiorly. It will come out on insertion of the denture, especially in the pterygomaxillary seal area. Now, if we talk about the correction, the selective reduction of the denture border is done, followed by the light pumicing. So that's all for this topic regarding the posterior palatal seal area. Please do not forget to share and like this video with your friends and your juniors. And you can also give your topics in the comment section. I will try to cover them in my next videos. Wish you success today and always.